It's nice to see sort of all of you. I'm so happy that you could join us for today's ADRC lunch talk. Hopefully you've got a sandwich or another cup of coffee or something and you're comfortable. We're so excited about this talk today by our director, Dr. Mary Sano, who's going to be talking about prevention of Alzheimer's disease and dementia in just a moment. I just want to say that we are recording this lecture, and after it's over in about a week or two, it will be emailed to you in case you can't stay for the whole thing, and will also be posted on our website if you'd like to see it again. At the end of the talk, if you would actually like a copy of Dr. Sano's slides, you can call, email, anyway, smoke signal any one of us. And in the next day or two, we'll have those in a PDF format and happy to share them with you if you'd like to take a little closer look. I know I enjoy doing that. So after the talk, we'll have some time for questions. And as we usually do, we ask that you post your questions in the chat down at the bottom of your screen, and we'll take as many as we can. And we'll have some polling questions for you just before we start that section at the very end. And it's terrific to see everybody. And I will hand it over now to Dr. Mary Sano, director of our ADRC. And she's going to share her screen so you can see the slides.
Well, hello all. It's so nice to have so many interested people. And I'm going to begin by trying to share my screen. Let me put this in the right mode. And all righty, let's see how I do. Do we have a good screen there?
We do. It looks terrific.
Great. All right. Well, thank you for being here. And I'm going to just put up my conflicts and consultancies, so you'll know that I'm doing quite a bit of work these days because everyone's so interested in Alzheimer's disease, and I wanted you to see this list of companies that I have worked with, including individuals who are running clinical trials of many types. So I wanted to talk about what I think of as today's very specific goals. I think what we're going to try to do is discuss knowing the difference between preventing cognitive loss and dementia, which we've talked a lot about, and preventing Alzheimer's disease. And there's a difference in the two, and we're going to talk about some of the specifics and how they might be relevant to our goals and desires to stay healthy as long as possible. Now, we've all talked about cognitive decline that precedes dementia, and if any of you have watched many of these, I'm sure you've seen this slide. This slide is a summary of all the ways that we can get cognitive decline. So we know that normal cognitive aging is affected by many things. It's affected first by age and by genetics and by our cardiovascular and our cerebral risk factors. We know that there are many things that affect brain health, and all of those things work to affect the brain, many different aspects of the brain, the synapses, which are the connections between the neurons, different cell types, and all of this can lead to cognitive decline. And what I show you over here is something that I still say is very true. The biggest best predictor of going on to dementia is having a memory deficit. And that's what this slide shows, is that if your memory score stays high, your likelihood of getting a dementia diagnosis is better than if your scores are low. And we know that cognition changes over time, but when our change is bigger than we expect for age, we might be on a slippery slope. All information we already know. And many people have been interested in protecting cognition and protecting ourselves from dementia. And so there have been many summaries of what's available. And in fact, right now, we really don't know how to completely prevent cognitive loss and dementia, but we know some things seem to improve or delay that loss. we've seen, and this is a summary by the National Academy of Science, Engineering, and Medicine that pointed to cognitive training and managing hypertension and physical activities, which have some benefits. And this is a World Health Organization that identified many other things that you've heard a lot about. But nevertheless, what these things can do is they can help us minimize cognitive impairment. And in summary, we know we treat our treatable conditions, we maximize our lifestyle, but really, if we want to make a difference in something like Alzheimer's disease, we really need to support research. And I want to tell you where the research has taken us and where it might go in the future. So I want to take a step into this very specific realm of what is Alzheimer's disease and what is Alzheimer's dementia. And several years ago, researchers and clinicians came together to define this specific disease. And Alzheimer's disease is defined by the presence of amyloid protein aggregating into clumps to form what we call plaques. It's followed by tau protein that aggregates to form tangles. And it also, the disease is also noted for neurodegeneration, right? But all three have to be present. And the neurodegeneration refers to the connections I spoke of, the synapses being less effective, not communicating as well between cells, and actual cell death, neurons cell degenerating and dying. Now that's the biology of the disease. And what's the symptoms of the disease? Well, I said memory impairment and other cognitive and behavioral problems that lead to impairing our everyday function. So one of the things that this framework that was created back in 2018 speaks to is the fact that some of the biology seems to occur before we actually see the symptoms, the memory loss, etc. And what I'm showing you is a series of curves that you've seen many times before that shows that this scale is from normal to abnormal. What you see is the amyloid goes up before anything else. We also see next in line is the synaptic dysfunction. That is the nerves starting to be less, the neurons starting to be less effective. And then the tau, the protein I told you that creates tangles, also starts to go up. And the belief is that our function and our cognition come in later. But what's important to note is these lines move around a little bit, but we do think that amyloid might be one of the earliest changes. Now, one of the things that's moved the field forward is that we're now able to visualize amyloid. We can actually see it in the brain. We don't have to wait for someone to die before we can measure it in their brain. So we now have a way to measure amyloid in the brain, and we're learning how to measure it in the blood. There are some tests that give us a very high predictability that if you have this blood test, you will also have amyloid in the brain. Now, this information has been used to develop agents, and you heard me talk about one a while ago called aducanumab, and now I'm going to be talking about another one called lecanemab that has some data published on it. This drug just received what's known as that accelerated approval, which means it changes the biomarkers, very much like we saw with aducanumab. But this one also has some data that would suggest it might even make a difference clinically. So this study was reported in the New England Journal of Medicine. I'm going to summarize key features of it for you. This study examined individuals, about 1,600 individuals who participated in the study, and their mean age was about 71. They're about 52% female. That's exactly what we expect in our dementia populations. They had very high mini-mentals, right? 25. That was the mean, but they could have a perfect mini-mental, but they had to have a memory deficit. We also know, as we know with Alzheimer's disease and in these early stages, that many of them had an apolipoprotein E4. So 31% didn't have one, and about 69% did have one. And in fact, 15% had two apolipoprotein E alleles. And you remember, I'm sure, that this is an allele that's highly associated with having amyloid in your brain and having Alzheimer's disease. And from a diagnostic level, about 38% of these people had a mild dementia, and about 62% of them were only called mild cognitive impairment. But they all had amyloid in their brain, and they all had a memory deficit measured in a specific memory test and measured with amyloid imaging. So one of the things that this drug has received approval on is from previous studies, we can see that it very dramatically removes amyloid from the brain. So this is the placebo group that had a level of amyloid that was consistent with a diagnosis of Alzheimer's disease. And this is the treatment group. And what you can see is by the end of the study, it was practically at a normal level for amyloid. So it was a very dramatic approval. But we've seen that before. The question is, can we see any clinical benefit? So in the next slides, I'm going to show you some of the clinical outcomes. The primary outcome in this study was the CDR sum of boxes. And many of you who participate in our research may have actually experienced taking this test. It's taken with a participant and with a study partner to give us their feedback on how a person's doing. And we ask about 6 different domains, starting with memory and orientation and how well you can do your daily activities and your community affairs and your judgment and problem solving. And what we see is that on this test, it's a very reliable and robust test, that there's a dramatic separation, that the lecanemab group actually showed less deterioration than the placebo group. One of the things I want you to see, though, is both groups are deteriorating, but the difference is pretty dramatic, and it starts to happen relatively early. This is the first time we've seen that kind of a robust effect using a study that had a very clearly defined population of individuals. There were other outcome measures as well. This is a very well-established test of cognition called the Alzheimer's Disease Assessment Scale Cognitive Portion, the ADAS-Cog. And what you can see is that, again, relatively early on, there's a separation, right? Both groups are deteriorating, but there's a separation, suggesting that there is a benefit, a clinical benefit. And also important is this measure from the activities of daily living. And what you see again is that the performance stays better with the lecanemab group, although it does continue to worsen. So these are very positive results. However, we have to talk about side effects. Now, the most common side effect was an infusion-related reaction. That usually means this drug, which is delivered by infusion, given every 2 weeks, can cause some distress at the site of the infusion. And this was the most common side effect. However, a more serious side effect is known as ARIA. That stands for amyloid-related imaging abnormalities. These are findings on the MRI, which people take routinely to see how the brain is changing. And there are 2 types of ARIA. One is called ARIA-E for edema, which means swelling. And what we found is that there was significantly more swelling in those individuals who were on the drug, where the placebo group had a much lower amount of this. And in particular, about 20% of those people who had that swelling had headaches, confusions, and other symptoms that go with it. Many of them resolved, but they are worth noting, and they're important to acknowledge that they are serious and need to be monitored carefully. There's another type of ARIA called ARIA-H, and that is associated with microhemorrhages or small bleeds. And again, you can see that there is almost twice as much in the individuals who were on the drug than in the placebo group. Now, I've told you many times, I think, about apolipoprotein E and how it increases the risk of dementia. If you remember, it's about 3 times the risk if we have one apolipoprotein E allele. As you may recall, we have, let me just take a step back and remind you, we each have 2, one from each parent, and the allele can be a 2, a 3, or a 4. And for those people who have an ApoE4, one E4 from one parent increases the risk of dementia 3-fold. And 2, one from each parent, increases the risk of dementia more than 10-fold. So what we can see is that in our population here, we had a very high number of individuals who had apolipoprotein E, about 69%. And what we also know is that it may be associated with a greater risk of adverse events. So let me show you some of that data. So apolipoprotein E4 and the risk of ARIA is the one that we're most concerned about. It increases, the risk increases with the presence of an E4. So non-carriers had about a 5% incidence of ARIA-H, and those who had one allele had about a 10% or 11%, and those who had 2 had about a 32% increase. So you can see, while those people who have the E4 might be more likely to be in the group that has amyloid and gets a benefit, they're also more likely to have a risk from the ARIA. So what I've shown you, I hope, is that we're moving in the direction of finding treatments that can actually change amyloid accumulation in the brain, reduce it dramatically, and they may even have a benefit on clinical outcomes. The importance of this study was that so many of the outcome measures, in fact, all of the primaries and secondaries, showed a beneficial effect with treatment. And in additional analyses, when they looked at subgroups, they found the same effect. If your subgroup is small, it may not be significant, but all of the groups, whether or not they were taking medications for Alzheimer's disease, whether they were old or young, whether they had mild cognitive impairment or mild AD, they were all showing this benefit. So this is exciting. That data will be reviewed by the FDA, and they'll determine if this will get what we call a traditional approval. But in the meantime, the question is, how can we use this information to actually prevent Alzheimer's disease? Not just dementia, but Alzheimer's disease. And what I'm showing you here, back when I talked to you about that framework and when different things appear, is a slide that shows us a combination of looking at biology and looking at our symptomatology. And what I'm showing you is a row of individuals who are unimpaired cognitively normal. And for those individuals who have normal biomarkers, no amyloid and no tau and no neurodegeneration, we expect that they would be cognitively unimpaired and very normal. But what about individuals who have positive amyloid and still have no cognitive impairment? Can we prevent them from getting cognitive impairment? Can we remove amyloid at a very early stage and see if we can actually prevent the disease and the dementia? Well, that's really what some of the work is that we've been doing for a long time. And there's reason to believe it's worth studying. So here is an example of an amyloid scan of a person who's a healthy control and has no cognitive problems. What you can see is some of them have negative amyloid in their brain. Amyloid is marked by the red. And what you can see is there are others who have positive amyloid in their brain. They actually have a head full of amyloid despite the fact that their cognition is normal. So the question is, can we target these individuals? First of all, do we know if this makes a difference? And in this slide, what I'm showing you is two different memory outcome measures. And in the top are the people who are the healthy elders, cognitively healthy elders, ones that have no amyloid in their brain, and those who have amyloid in their brain, even though they're cognitively healthy. And what you can see is that over 3 years, the ones who have amyloid in their brain actually show deterioration on a cognitive test. This is on a verbal memory test, and this is on a visual memory test. So we do know that the presence of amyloid is going to increase the likelihood of some cognitive change in even if you're cognitively normal and cognitively healthy. Now, most of these people, even at the 3 years, may remain non-demented or non-MCI, depending on where they began. But we do see that it's marking a transition. So our question is, can amyloid removal before symptoms prevent Alzheimer's dementia? If you have your amyloid, we might say you already have the beginnings of Alzheimer's disease, but do you have the dementia? That's what we all want to protect ourselves from. So this study is recruiting individuals from ages 55 to 80 years old, okay? And what we do first is we determine if you're likely to have amyloid in your brain by imaging by taking a blood test. So it's a stepwise approach to deciding who's right for this study. If in fact the blood test says you might be eligible, rather than going through all of the work that someone has to go through, and you'll see all the stages, we can reduce that burden for many people by determining with the blood test what the next step might be. If the blood test suggests that you are likely to have amyloid, then what we do is we screen. We screen for healthy cognition. That means no symptoms, no serious memory or cognitive problems. We check for healthy brain. We take images of your brain with our MRI and make sure you don't have any risk factors that would increase the likelihood of that ARIA. We can make sure there's no evidence of any microhemorrhage or inflammation that would make us worried that a drug would hurt you. We do other things to minimize risk factors, and we'll talk a little bit more about them. So what does it take, though, to participate in a study like this? Well, it's a very long study, and that's and it has some burden associated with it. So I wanted to sort of go through what the details are. First of all, as I mentioned, this drug requires treatment by an infusion every 2 weeks, right? So frequent treatments, you have to come into an infusion center every 2 weeks. Now, in some cases, if you have very mild hint of amyloid, we might try doing it every month because you may not have enough that it would need this. It's a long study. It's 216 weeks, which is 4 years of treatment plus some time to do all of our screening. It's a careful and cautious study. We monitor MRIs every month for the first 9 months because we know that the ARIA changes are most likely to occur in the beginning. And so what we do is we very carefully monitor whether or not there's slight changes occurring, make a decision about whether we should put more time between doses or maybe stop treatment for a while. Very careful monitoring. We also monitor health and medications. There's some suggestion, because this drug can cause some bleeding, that we should be sure that people are not taking blood thinners, which might make the situation worse, or at least we need to balance the risk and benefit of each of those treatments. So you can see that it's a pretty extensive study and the commitment is very high. So this study, known as the AHEAD study, as I say, the AHEAD 3, 4, 5 study, has pros and cons. And I want to summarize some of the ones I think about, but then when we have our Q&A, you'll be able to tell me what you think might also be a con or what might also be a pro. Because the importance is being sure the study measures the things we want to know, but treats safely. So the pro is that you would know your amyloid risk. With the blood test, we can give you confidence about high or low amyloid. If you go on to imaging, you'll know more precisely your amyloid. We also have an opportunity for people to know their apolipoprotein status. We can determine that if you so choose to have it. And that information can help you think about whether or not you want your participation to go forward, given the differential risk that it may cause. It allows us to catch the AD pathology, the Alzheimer's disease pathology, at the earliest stage. We would never be measuring your amyloid if you have no cognitive problems, no risk. At this point, it's actually using an approved medication. Now, the medication is approved for those people who have symptoms and for those people who have amyloid, and it is approved based on what we call accelerated approval. So we have good confidence about the removal of amyloid. We have strong evidence that it may have a clinical benefit, but that benefit needs to be reviewed by a regulatory agency before we know for sure whether it'll meet a traditional approval. And the other thing that many people say is so important to them when they participate in our research is a research team that will answer questions for our participants, for their study partners, for their doctors. It's really important to know when you participate in something like this that you'll get the answers that you want when you want them and when you need them. You have frequent contact with the study team because the infusions are so frequent, and we're always available to answer questions or to hear about any changes that you may have. But this is not a study that isn't without risk, and we should really monitor both pros and cons when we make decisions about a study. So the same first benefit is knowing your amyloid risk. That may also be a con. Are you ready to know what your amyloid risk is? What if it turns out it's not amyloid positive? Well, if you're asymptomatic, if you don't have any problems, that might give you some confidence. But what if it is positive? And how will you share that? I think a chance of serious side effect cannot be minimized. I have told you that the numbers are low and we try to manage them, but there can be serious consequences. They, if not managed properly, if people don't follow protocol, if they don't fully inform us about the other medications they're taking, the risk can go up. And while it's an advantage to be using a medication that's approved, it's important to realize this is a new medication and we have very little experience with it. It is with our experience that we found out about the potential risk that comes from blood thinners or anticoagulants, as we call them. There may be other risks that we have not yet learned about, and we'll learn more about as the drug gets greater experience. And it's important to realize that there are frequent visits that can be burdensome. It's also important to realize for true safety, you really need to be able to make all of those visits. So it's quite a commitment. And I would argue that no one has to make a decision in one direction or another without weighing all of these important issues. with themselves and with their study partners and with their families. So when I talk about studies, I think it's really important to remind people that not all studies are for all participants. So when we pick our inclusion criteria, it's to ensure safety, or limitations by age or other comorbidities or other medications can also be for safety. So for example, if it was decided that you were interested in this study, but the anticoagulation or the blood thinner was a contraindication, that's because of safety, not because we want to exclude anyone. We also have to ensure the ability to measure efficacy. And for many people, what I say that means is, we need proficiency in English or Spanish right now, or it means that your visual acuity has to be good so we can use our outcome measures, or your hearing has to be good enough so that you can hear us. These things can make it difficult to participate and difficult for us to be able to know if all we put you through will give us correct information. So that's really important to keep in mind. Exclusions aren't to let somebody out or to not allow somebody to have a chance. It's really built around safety. Also, how to choose. Well, we want to select by interest. If this is a disease, this biology is a disease you're at risk for, you may have great interest in participating in this study. You have to work with people you trust, and you can build trust both because you know them and because you ask questions. So we really think that's important. I think it's also important to be honest about how much you can do. If once every 2 weeks just doesn't sound like something you could do, or coming in once a month for a scan seems burdensome, we have to be sure that we can do things safely. So be honest. Not all studies are for all people. Ask questions. And keep in mind, you can always change your mind. You can start to be screened and then decide the risk seems too high, or the burden seems too high. Or you can decide, I didn't think I was really going to do this, but I've decided I trust this team, and maybe we'll give this a shot. So those are my thoughts on this drug and on this particular study. So I want to open this up to questions. I'm going to turn it back over to Dr. Sewell so she can give us some thoughts on how we can share more information with you.
Terrific. Thank you so much, Dr. Sano. So let me